Good morning, everyone. It's just 8 o'clock, so I think we should begin the meeting so we run on time. I'm Georgia Demetriou. I'm the academic head for medical oncology in the Department of Internal Medicine. And it's my great pleasure today to introduce Dr. Sam Molepo. Dr. Molepo is a specialist physician and currently a fellow in the Department of Medical Oncology. He is going to be talking to us today on recent advances in lung cancer. And it's very appropriate that Dr. Molepo was the one doing this talk, as he has been involved with lung cancer and lung cancer diagnosis, with his MMed being based on the use of ultrasonography in working up lung pathologies in physicians. So Dr. Molepo is very keen and interested in our department in multiple cancers, lung cancer, breast cancer, and gastrointestinal cancers. So Sam, I will not delay any further. It just remains me to welcome you, and we'll listen to your talk. Thank you very much.
Thank you very much for that kind introduction, Prof. A good morning to everyone who's tuned in. Again, I'll be just giving you some advances in lung cancer in our working professional oncology. I just want to start with a case presentation. I've got a 52-year-old female patient. She's a Zimbabwean national. She grew up in Harare and has specifically traveled to South Africa for treatment. She's never smoked in her life, and there's no identifiable secondhand smoking. So let me just switch off one of the devices. Apologies. She has never smoked in her life, and there's no identifiable secondhand smoking. There is, however, biomass fuel exposure in early childhood, all the way up to the age of 14. They used firewood in the household. She is HIV positive on first-line therapy, and she's well controlled and following up with her GP in Harare. She is a mother of 3. She was referred to us by a private oncology service in Harare, diagnosed with de novo metastatic lung adenocarcinoma. The history stretches back to 2018, and she had presented at that time with tremors, as well as what appeared to be a monoparesis of the right upper limb. There was the initial working diagnosis of stroke. However, the CT brain revealed a left parietal cerebral lesion that looked to be a metastatic tumor in nature. And she proceeded to have a biopsy afterwards, which showed metastatic papillary adenocarcinoma. As per the report, it was in keeping with the lung primary by immunohistochemistry. Although the supplementary page showing the immunohistochemistry was missing, I have asked the family to go collect it. She had a CT chest done at the same time, which then proved this right upper lobe apical segment mass that was the primary. The tumor was already locally advanced, where it was engulfing and narrowing the right upper lobe bronchus. But it was anyway a stage 4 because she had presented de novo with cerebral mets. She proceeded in April of 2021 to have whole brain radiation, 30 grays that was given in 10 fraction over 2 weeks. And then she had chemotherapy with carboplatin and paclitaxel and received a total of 8 cycles. Then she had a staging study, which, the oncologist was quite worried that it may have represented progressive disease. There was the report that the primary mass had somewhat been reduced in size, but I don't have any dimensions, and specifically I can't report on RECIST criteria. However, what was worrisome was the presence of new adrenal mets. They were not reported on the initial images done. And in fact, the initial images were on the basis of a CT. But per the oncologist, the CT had low enough cuts and they didn't see the mets then. But the other concern was just to rule out local complications because she had new pleuritic chest pain. And just to say that cardiac workup was negative for this. On examination, she'd had an oral thrush. There was no peripheral lymphadenopathy, no pallor, jaundice, cyanosis, or clubbing. I had also looked for features of a Pancoast tumor, which she didn't have. She also didn't have any features to suggest superior vena cava obstruction syndrome. She had otherwise equal breath sounds bilaterally and no adventitious sounds. The cardiovascular examination was also unremarkable. On central nervous system examination, she was a bit slow to respond, and the only residual deficit was a pronator drift. Otherwise, she was fully ambulant, and power and tone testing was normal. The decision on the case was to start her as second-line metastatic based on the new adrenal mets with cisplatin and gemcitabine. We did a chest X-ray just to rule out pneumothorax or pleural effusion as a cause of operative pain, but none of that was evident on the chest X-ray. I had ideally wanted to re-image her at that time in terms of a new staging scan, and we actually booked it, but it would only be done just last week, actually. Up to this point, she has received cycle 4 of her gemcitabine and cisplatin. So again, I sadly don't have images from Harare, but these are the images that we have from last week. And you can see that there is in fact a residual, I don't know if my error can be seen, there's a residual apical mass with a bit of speculation in at the right side. Of note is this cystic lesion that was actually described in the first scan in Harare. I asked for a bit of advice around for this, but this probably is a benign representation, perhaps childhood, a cyst that she developed in childhood or as a post-infectious complication with her being HIV positive. Those are just some of the cuts showing the same disease. We also scanned the brain. We can see there's still a residual parietal mass. Again, I've asked the family to collect the images from Harare so that we can do a comparative analysis and see if things have got smaller or bigger. Just further cuts through the brain. So again, you can see there's a brain lesion. There is in fact a bit of degeneration around it, cystic formation as well. All right, so if we could just move into the core lecture for today. Lung cancer remains a leading cause of cancer-related deaths. It's still the first cause of cancer deaths among males and second among females. And globally, there's about 2 million patients that were recorded in 2018 with about 2 million deaths of the same year, and that's how high the mortality rate is. The mortality has, however, plateaued among male patients, and it's likely due to the earlier smoking cessation efforts. It remains a number one risk factor for, smoking remains the number one risk factor for lung cancer. Approximately 90% of all lung cancer patients have an identifiable smoking history, and it confers a 10 to 30-fold risk if you compare that with non-smokers. The number of cigarettes becomes important as well as the duration, which in total give you a pack year history. And patients who stop smoking for more than 15 years actually reduce their risk by 80 to 90%, but never quite equal to the non-smoking population. There's improved outcomes in patients who do cease smoking. And I just wanted to make a note that, even patients who can't cease smoking, but can reduce the number of cigarettes will still reap a benefit. There is a reduction in all-cause mortality in these patients who stop smoking. There is a reduction in tumor recurrence, as well as that of secondary tumors. And just a reminder that the tumors are not just lung, they're at risk for other tumors in the body, including larynx. The relative risk is also increased in other forms of smoking. Specifically of importance is secondhand smoking. And it seems that patients who are exposed to secondhand smoking from childhood have an even higher risk than patients who are exposed in later life. Just to say as well that dagga and cigar smoking also confer risk. Biomass fuel exposure as we had in our patient, as well as urban pollution, you know, when we're driving in the highways, inhaling a lot of exhaust fumes. There's evidence, mounting evidence that e-cigarettes are also associated with harm, but large-scale data are still pending on this. There's importance of occupational exposures, and asbestos is probably at the fore, and it's especially important when it's combined with lung fibrosis, where it constitutes asbestosis as a disease. These patients are at higher risk than just being exposed to asbestos alone. It is a dose-dependent relationship, and the risk also depends on the type of asbestos fiber, so that your amphibole fibers confer greater risk than your chrysotile fibers. And this risk is both to adenocarcinomas as well as to mesothelioma. And it is an additive risk when combined with smoking. There are other exposures such as radon, which is a product of gaseous decay of uranium-238 as well as radium-226. It was initially well described in underground uranium miners, but we now know that it can be found in the soil, it can be found in the rock, it can be found in groundwater, and therefore it becomes a domestic issue where it can accumulate in homes. There's other metals such as arsenic and nickel and your polycyclic aromatic hydrocarbons that can also confer a risk to lung cancer. And then on an iatrogenic side, radiation to the chest can also confer risk to lung cancer. It was well described in Hodgkin's lymphoma. And just to say that it's also multiplicative risk when we've got smoking in addition. Other risk factors for lung cancer include benign lung diseases, especially those that are driven by chronic inflammation, COPD being an important one, and this is even when adjusted for smoking. TB, as well as alpha antitrypsin deficiency, are also important risk factors. And then again, in our setting, HIV status is an independent risk factor, as especially adenocarcinomas happen to be non-AIDS defining malignancies, as was the case in our patient. Just some local statistics. Our top 5 invasive cancers in South Africa, lung cancer still remains number 3 behind prostate and colorectal. Elsewhere in the world, they're still seeing it in females, especially in East Asia, but in South Africa, it's not in our top 5. This is just data from the National Cancer Registry from 2019. Just a word on screening. It is used elsewhere in the world, in especially our higher income countries in the Northern Hemisphere and elsewhere. There is no recommendation as yet by our Department of Health. However, it is recommended by the South African Thoracic Society. So the question to ask would be, well, who should we be screening? There's a bit of difficulty defining the at-risk population. However, most guidelines agree that your heavy smokers, which are defined as greater than or equal to 30 peg years, as well as all heavy smokers who have ceased smoking but are less than 15 years from cessation. The ideal age is between 55 and 74. And that's just for practical reasons. Patients before the age of 55 may not have accrued enough injury to develop lung cancer. And patients on the other side of 74 may not be fit for a lot of the multimodal forms of treatment required. The screening tool of choice is low-dose CT. There's no role for chest X-ray for screening, and there's no role for sputum cytology. There is not, however, a lot of clarity in terms of how frequently the low-dose scan should be done if it's negative at the first one. However, our local thoracic society advises annual low-dose CT. There are some limitations to screening programs. The biggest of which is that the patient must be ready to undergo a lot of further investigations. They have to be agreeable to surgery, they have to be fit for surgery, and they have to have a good baseline performance status, which may be challenging in patients who have COPD or other complications of their heavy smoking. The mortality benefit has been shown in centers that handle quite a lot of thoracic oncology, and especially with cardiothoracic skill. We also need radiology skill to be able to interpret the CT scans, especially because they're low dose and because there's a high rate of false positives when we're looking at solitary lung nodules, for example. We ideally also need a multidisciplinary team that's going to handle specifically thoracic malignancies. And this is just to show you how horrid the classification is by the WHO from 2021. There are other simplified ways of thinking about the classification of lung cancer. This is an oldie but a goodie, where we divide lung cancer into small cell and non-small cell. And then the non-small cell subgroup is then divided into adenocarcinoma, squamous cell carcinoma, as well as your adenosquamous, where there's 10% of either. And your large cell type, which is your null type, where the immunohistochemistry that usually leads you to other diagnoses is negative. And just to say a few things on that. So we usually use immunohistochemistry where TTF1 tells you about lung origin, and especially in adenocarcinomas, where your P40 tells you about squamous cell carcinomas, and your chromogranin A or synaptophysin tells you about neuroendocrine tumors. So your large cells are usually null for any of those. And then there is still the sarcomatoid as well as salivary gland subtypes. This is just local data from work that we did at Helen Joseph Hospital. Here we did an analysis of lung ultrasonography derived diagnoses. So they use lung ultrasound there for a lot of work. If they've been called for things like effusions and consolidations, and people aren't sure what they're seeing, the lung unit there can do ultrasonography, and especially a lot of ultrasonography guided procedures. So some of the histology that we found was that adenocarcinoma remains the predominant cause of these lung lesions. I will say that because we're using ultrasound, these will have been peripheral lesions. So adenocarcinomas would have come out top anyway. Squamous cell carcinomas were second at 12%. Small cell lung cancer was third at 8%, followed at the same rate really as neuroendocrine tumors. And there was in fact non-Hodgkin's lymphomas presenting with peripheral lesions, as well as Hodgkin's. Just to request that there's no further publication of this. It's still under peer review. So just the pathobiology. This is just to reiterate that large, busy diagram that I showed. But basically, the WHO divides lung cancer into precursor lesions, which can be adenocarcinoma versus squamous type, and into minimally invasive versus versus invasive. And just a note on the term lipidic, they use this term to describe a growth pattern, but also as a histologic subtype. And it can be both invasive and non-invasive. And it's important in patients who present with a pneumonitis or a pneumonia kind of malignancy. And I remember seeing one when I was a registrar. Patient presented as a pneumonia. We actually re-imaged this patient after 6 weeks because the pulmonologist was concerned. And on re-imaging, very little had changed. And a CT showed that this was probably a malignancy. It also describes, it breaks into, the adenocarcinoma subtype into mucinous versus non-mucinous, and your squamous types into keratinizing versus non-keratinizing, as well as a subgroup called basaloid. Its pathogenesis, so in terms of lung cancer, there's a classic multi-step process that's described. It's best known for your squamous cell carcinomas, especially in the setting of smoking, where there's repeated epithelial injury leading to chronic inflammation, leading to adaptive metaplasia and severe dysplasia and carcinoma in situ, and then leading to invasive carcinoma. There is evidence that since the introduction of low-tar cigarette filters, there has been a reduction in this sequence. and therefore we're not seeing as much squamous as we did before. However, now the carcinogens are being delivered distally, leading to our adenocarcinomas. And just a word on your molecular subtyping. So your non-small cell lung carcinomas, at the moment, a lot of testing is being done to subclassify it into molecular subtypes. And this can be done either with fluorescence in situ hybridization FISH or with immunohistochemistry. But a lot of centers are choosing next generation sequencing as a tool of choice. And we'll be speaking a little bit about some of these markers, with EGFR probably being the most important. And this pie chart, I just wanted to show you that in adenocarcinomas, what's the proportion of patients who have positive molecular drivers. And you can see in this diagram to the right-hand side of your screen that EGFR constitutes 15% of total adenocarcinomas, whereas KRAS constitutes 30% of your adenocarcinomas. There's still a large group of patients with an undetectable or unknown mutation. And then just to say as well that there's molecular subtyping for squamous cell carcinomas as well, with a bit of crossing over. This diagram, I just put it in to show you how big the proportion of your never smokers seem to be driven by mutations, and especially if you look at the EGFR again on the right hand side. This diagram is a bit important for our talk, where we locate some of these molecular changes. I just want to show you. I don't know if you can see my arrow, but EGFR is a transmembrane receptor, and it has downstream molecular signaling, intracellular signaling, where your RAS, RAF, MEK, ERK pathway is quite important and will come up as we speak. Your PI3 kinase, AKT, mTOR pathway, as well as your JAK-STAT pathway. If you look, there's other transmembrane receptors that we'll speak about. CMET will come up later. ROS is also a transmembrane receptor. It will come up later. And then there's your anaplastic lymphoma kinase shown there in red, which we'll speak about later as well. And then just in that yellow cartoon is your mutant KRAS, which again we'll speak about shortly. So just the EGFR, it stands for epidermal growth factor receptor. It's a receptor within quite a large family of ERB receptors, which are tyrosine kinases. Here, a ligand usually binds to the receptor, leading to homodimerization. However, just say that heterodimerization can also occur with other ERB receptors within the family. There's multiple intracellular signaling pathways, as we showed in that diagram, but with the eventual pathway leading to cell proliferation, migration, and adhesion. And just to say that understimulation of this receptor has been implicated in Alzheimer's, and overactivation, of course, may lead to cancers. The RET mutations, here, it's a big family going from RET1 to 59. They are proto-oncogenes, and they usually encode for a tyrosine receptor kinase. They're important in the autonomic nervous system development of the kidney and the gut, where loss of function mutations usually lead to Hirschsprung in neonates or in infancy, and gain of function mutations usually lead to endocrine carcinomas, and they're well described in medullary thyroid carcinoma. So specific gene fusions then happen to drive 1 to 2% of our adenocarcinomas. NTRK fusions. So again, it's a family of tyrosine kinases. The term stands for tropomyosin receptor kinase, and the usual function is to regulate synaptic strength and plasticity in the mammalian nervous system. And common ligands here are neurotrophins, and they're important in the survival as well as function of nerve cells. Just a word on lung cancer in smokers. So a third of all lung cancer happens in non-smokers. It's emerging now with the worldwide reduction in cigarette smoking. There isn't a lot of data presented on non-smokers, mostly because these registries don't often include smoking status. There's a lot of work coming out of Asia because 60 to 80% of women there happen to be never smokers. These patients tend to be younger than the smoking patient, and there's a female predominance, although the mortality remains high among males. And small cell lung cancer is almost never seen in never smokers, and most cases of non-smokers happen to be adenocarcinoma, but with 10 to 20% still being squamous. So just the definition, a never smoker is defined as someone who smoked less than 100 cigarettes in a lifetime. There's other risk factors for never smokers to develop lung cancer, which include some of the environmental factors that we mentioned earlier. However, there's clustering in families, especially reported in East Asia. There hasn't been a lot of consistency in genome-wide associations. However, EGFR and HER2 are coming up as possible germline driving mutations. There's a word on actionable mutations, which basically speak of driver mutations that are targetable by therapy. This subgroup of patients is about 78 to 92% in non-smokers versus 50% in smokers. And again, EGFR happens to be probably the most important activating mutation that's targetable, with exon 19 deletions being well described, with our leucine to arginine on 858 mutations being described, as well as our T790 mutation, which is threonine being substituted for methionine at the 790 position on exon 20. We often see this in patients who have been treated with EGFR therapy, but then acquire resistance on therapy. And when we do perhaps liquid biopsying, we find that they harbor this mutation. And just a word that this mutation, if found in never smokers, and even if found at genetic counseling or germline testing, will still confer a risk for lung cancer in spite of other risk factors. The KRAS pathway, it tends to be more prevalent in smokers, and just a new trial released, or preliminary results released this year showed that a larger proportion, about 94% of patients were smokers who harbored this. It portends a poorer prognosis, and the G12C mutation is the one that's currently targetable. And then just a word on immuno-oncology. This is an evolving field, and I'll touch on some of the drugs shortly. And just say that T cells have a complex system of detecting mutant or abnormal cells, which involves checkpoint signals. You've got your programmed cell death receptors, PD1 as well as PD2. But tumors then are able to generate what we call PDL1 or PDL2, which can bind to PD1, PD2 to disengage T cells. So effectively blinding T cells so that they're unable to recognize tumors as abnormal. We do immunohistochemistry for PDL1, and in the setting of lung cancer, and specifically for use of pembrolizumab, we use what we call a TPS score. And a TPS score more than 50% would put pembrolizumab as your first-line indication. A TPS score, so in the second-line setting, you don't require as much, and up to 1% of your TPS score is high enough to use pembrolizumab. There has been other patients without PDL1 positivity who can benefit from immunotherapy, such as patients with high tumor infiltrating lymphocytes on histology, or patients with a high tumor mutational burden on genetic or on next generation sequencing. This is just the staging of non-small cell lung cancer, the TNM staging, And I just want to highlight just some of the important bits under T1. We see that size is what's being used there as cutoffs, so that a tumor that's less than a centimeter in the greatest diameter is a T1A. If it's greater than a centimeter but less than 2 centimeters, it's a T1B. If it's greater than 2 centimeters but less than 3 centimeters, it's a T1C. T2 lesions are greater than 3 centimeters but less than 5, or if they involve the main bronchus, regardless of the distance from the carina, if it invades the visceral pleura, or if it's associated with atelectasis or obstructive pneumonitis. And then the rest of the slide we can move past. Just nodal staging, very important, is that patients with mediastinal or subcarinal lymph nodes constitute N2 disease, and patients with mediastinal lymphadenopathies on the contralateral side will constitute N3 disease. This will become important just shortly. This is just a grouping staging of your non-small cell lung cancer. It is a bit of a complex system of staging, and if you contrast that with small cell lung cancer, where we just divide it into limited stage as well as extensive stage. I want to whiz past these so that I can get to the treatment, but there's a bit of a pre-treatment evaluation that's important to do. Of importance there is imaging. So we require a staging scan, especially if you're just going to have a chest. We may need a brain scan in small cell lung cancer, but also for all your other lung cancers where you are looking for a curative intent, we need to just rule out brain metastases. There's a role here for PET, for nodal staging, and just to say that these patients can have other granulomatous diseases which can make your PET positive. Right, multidisciplinary teams, especially with pathology, are quite important because some of these patients, as we've shown, may have driver mutations. So you may need to go back to your initial tissue to do subsequent testing as a patient needs subsequent therapies down the line. Just another diagram showing the importance of imaging. So we need to check the mediastinal lymphadenopathy. If your patients have no mediastinal lymphadenopathy or any other lymphadenopathy, they've got peripheral tumor and it's a small tumor less than 3 centimeters, you can go straight to surgery. Patients who have N1 disease, so below mediastinal, with a central tumor and a tumor that's larger than 3, you need to just rule out N2 disease on those patients and do an EBUS, well, a minimum of EBUS or EUS, assess mediastinal lymph nodes. If they're negative, you can go straight to surgery. If patients have mediastinal lymph nodes, we need tissue confirmation, again, by endoscopic means. If your mediastinal lymph nodes are positive on EBUS or EUS, you would employ a multimodal form of treatment. If the lymph nodes are negative, but you're highly suspicious based on your imaging, ESMO recommends that you do a video-assisted mediastinoscopy and again have another look at those nodes. If they happen to be truly negative, you go straight to surgery, but if they're positive, multimodal forms of treatment are required. This is just a word on brain imaging, which we've already mentioned. Just a bit on preoperative workup. So if we're gonna consider resection in these patients, we need to ask the question, well, will they do well after surgery? Are they fit? Do they have enough lung reserve to have resection? So we do an FEV1 and a DLCO as part of your pulmonary function testing. If they're both normal, above 80%, you can go straight for resection without much limitation. If, however, any of your 2 values are below 80%, then there's a few important steps to follow, with the first one being exercise testing, looking at your total oxygen consumption. This is pretty much just a measure of fitness. And if your patient measures poorly, ESMO doesn't recommend surgery on these patients. If, however, they do well on your exercise testing, you can proceed to surgery. If your patient is a bit borderline, and I mean, the values are 10 to 20 moles per kilogram per minute, then they recommend split function testing of the lung. If either your FEV1, your predicted post-operative FEV1 or your DLCO is above 30%, then you can resect the patient, but only up to a certain extent. And if either of those values are low, then you do your predicted post-operative oxygen consumption. If that's still low, they don't recommend an operation, but if it's above 10, you can also do a resection up to a certain extent. This diagram I won't go through, but basically it asks the questions, well, some of the patients may have COPD with emphysema, where lung volume reduction surgery could improve their function. So why not do it at the same time as you're doing the operation? And the answer is you can. And the only questions you'd have to ask is the tumor located in the same segment as, say, the bulk of your emphysema, or would you have to do surgery on different lungs? Would you have to do surgery on different segments? This is just your cardiac workup preoperatively as well. I won't go through it, but it asks the questions, well, what if your patient had myocardial ischemia and required intervention? And the answer is, if they require an intervention, do the intervention, but delay surgery for up to about 6 weeks. So just the management in terms of stage 1 and stage 2 disease, resection remains the cornerstone of treatment in these patients. You do have to look at those, your lung reserve. You do have to look at your patient's functional status to determine whether or not the patient's operable. If your patient's inoperable or they're unwilling to go through surgery, you can look at radiation with curative intent. In this setting, we prefer stereotactic body radiation. If it's unavailable, hypofractionated high-dose radiotherapy. The other option for these patients could be definitive chemoradiation, especially if they have node-positive disease. You can go straight to upfront surgery in very early disease with your very small tumors and with your node-negative disease. But the minute they're node-positive, you have to consider other modes of treatment post-op. But your N1 diseases would not be upstaged in these patients, so you can go straight to surgery. Any patient who's got more than N2 disease would be managed as a stage 3, which we'll come to shortly. Just a word on post-operative management. So again, for your early lesions, if you get a complete resection, what we call an R0, so no residual tumor was left behind, then you can observe these patients. If anyone of these patients has more than an R0 resection, so in other words, they have either macroscopic positive margins or microscopic positive margins, those patients, they recommend re-resection or radiotherapy. Patients who have slightly larger lesions, but with no nodes, then you can risk stratify them. And ESMO gives a bit of word on how to do this risk scoring. And your high-risk tumors will include your poorly differentiated tumors, including your non-benign neuroendocrines, vascular invasion, if they had done a wedge resection, tumors more than 4 centimeters, involvement of the visceral pleura, as well as unclear lymph node status. If any of those patients, if any of those features are there, that's a high-risk patient, and you consider adjuvant treatment. In stage 2B, if they've got T3 invasive disease, we'd also recommend adjuvant treatment for them. Just in terms of adjuvant treatment, you've got a few modalities, the first of which is chemotherapy. This is indicated in N1 as well as in N2 disease, so stages 2 and 3. It confers a 4 to 5% improvement in overall survival at 5 years, and we're using cisplatin-based doublets. Studies were originally done with vinorelbine, but we can use pemetrexate if the patient has a non-squamous histology. We can also use others such as docetaxel, paclitaxel, gemcitabine, and nab-paclitaxel. Carboplatin can be used if patients are not thought to be tolerable to cisplatin. And just to say that stage 1A is the only setting where chemotherapy resulted in worse outcomes. Stage 1B, the benefit has best been shown in patients with tumors that are larger than 4 centimeters. And just to say that chemotherapy is an important consideration in resected patients who had positive margins. So in other words, more than an R0 resection. So other modalities, so radiotherapy, as we've mentioned, we prefer stereotactic body radiotherapy. However, in its absence, you can use radical. It's indicated in patients with early stage disease, especially in peripheral tumors, patients who are not operable due to comorbidities or due to a performance status, and in patients who are declining surgery. And just say that stereotactic radiation uses smaller margins, so you get up to sub-millimeter precision in terms of the field. It uses multiple radiation beams or arcs, and it's biologically, we give 100 gray as a minimum. And just to say that when you use a stereotactic modality, you lead to a reduced toxicity in the surrounding tissue. There's lower rates of acute toxicity or deterioration in performance status, but there's other toxicity, especially lung fibrosis, which is best seen in patients with underlying ILD or in underlying honeycombing for other reasons. Late side effects of this modality would include rib fractures, worsening in your MMRC, as well as ventricular tachycardias. Yeah, so just to say that stereotactic radiation is not recommended for patients with central tumors, as it causes high rates of toxicity. In that case, conventional radiotherapy would be preferred. In tumors more than 5 centimeters, we would also prefer conventional radiotherapy. And then just the word that radiotherapy is also indicated in patients who had positive margins after resection, and especially if resection is not feasible or the patient has declined further surgery. And just patients who cannot tolerate surgery or cannot tolerate radiation, you do have an option of radiofrequency ablation. So stage 3 is a bit complex, so I'll just try and summarize it. But in T3 patients with T3 disease or N1 disease, you can still manage them similar to your stage 2, where you can go for upfront surgery and consider, and must give them adjuvant treatment after. But for your locally advanced lesions, you're going to need to do a bit more work. We may need an MRI of the thorax, including the thoracic inlet. PET and CT will be important in these patients, if not previously done. And these patients will definitely need imaging of the brain. If they've got N2 disease, so mediastinal lymph nodes, then they need pathological staging. We need to get preoperative invasive forms of diagnosis. And just which patients under stage 3 are resectable. So patients with just a large tumor, but no nodal disease, where the nodes have been shown pathologically to be negative, you can consider resection. Patients with N2 disease, but single station N2 disease, you must have sampled other nodes, and if they've all been proven benign, this patient can be considered resectable. If you've had induction therapy and the patient has had nodal downstaging, you can consider them resectable. And if after a consultation with your MDT, we're of the opinion that pneumonectomy can be avoided, then these patients will be resectable. So just the note here is the surgeons must have skill, and they'll probably be able to tell us if they can achieve an on-node resection. We can give neoadjuvant chemotherapy to patients with locally advanced disease. The role is best demonstrated in the setting where we need downstaging and to limit the extent of surgery. Concurrent chemoradiation is a cornerstone in stage 3 disease, especially unresectable, where we give a platinum doublet followed by radiation and then given further chemotherapy after. For N2 disease, as we've already mentioned, you need pathological staging in these patients. But if you discover that they have N2 disease postoperatively, you would add adjuvant chemotherapy. If you identify N2 disease preoperatively, you've got a few options. The first one is you can offer these patients upfront surgery followed by adjuvant chemo, or you can go with induction chemotherapy followed by surgery, or you can go with induction chemoradiation followed by surgery. If your patients have multi-station N2 or N3 disease, you would offer them definitive chemoradiation. And in this setting, only the surgeon or the combined MDT will be able to tell us if they're able to resect. So which patients would be considered unresectable? It's those patients that even after induction therapy, we didn't think that an on-node resection was possible. This group of patients, we would offer definitive chemoradiation, and we've got a few options. We can go with sequential, where we give chemotherapy and then radiation, or we can go with concurrent, where we give the two modalities at the same time. This is more preferable in younger patients, but it's limited by side effects such as esophagitis. There is a higher rate of mortality in patients with concurrent chemoradiation, and the risk factors for that being a bulky tumor, or if they had poor pulmonary function testing before. And then just another important risk factor to both to sequential as well as concurrent would be the risk of pneumonitis. So that's just me showing how vast and nuanced the management of locally advanced diseases, but I can't go through all of it. So just a word is that following the management of these patients with definitive chemoradiation, you would offer consolidation therapy with durvalumab or atezolizumab for a year post multimodal treatment. Right, I just wanted to get to metastatic disease. This is a bulk of what we do in the unit. At the moment, we need to ask the question, is the tumor driven by oncogene mutation, or oncogenes or driver mutations? Look at your comorbidity, look at the performance status of the patients, and then think about potential side effects or contraindications to the use of your treatment. If you're using platinums, look at renal function. Platinums can be myelotoxic or neurotoxic. And if you're looking at taxanes, there's also neurotoxicity as an important limiting side effect, and allergic reactions. If we're thinking about immuno-oncology, immunotherapy, there may be a contraindication in patients with severe autoimmune disease, or any patients who need immunosuppression, such as those who've had organ transplantation. Very important to educate our patients and to listen to their preference. Smoking cessation should still be advised, even in patients with advanced disease. And again, the role of a multidisciplinary team. If your patient doesn't have any oncogenic drivers, then we want to look at your PD-L1 status. If your patient's got a TPS score of more than 50%, then we can use single agent pembrolizumab, especially if it's a non-squamous cell type. Your other options in this setting is to combine your immuno-oncology with chemotherapy, with carboplatin or pemetrexate. We can also go with atezolizumab with carboplatin, paclitaxel, and bevacizumab, which is a vascular endothelial growth factor monoclonal. You can also consider atezolizumab with carboplatin and nab-paclitaxel. If your patients have negative PD-L1, or they've got a low status with a TPS score of 1% to 49%, then you would consider, per ASCO, you can still use pembrolizumab, but combine it with chemotherapy. In our setting, we pretty much treat our patients in this sort of variety because we are unable to test for PD-L1, we are unable to test for driver mutations, but as well, we don't have these newer agents. But a platinum-based two-drug combination is still a standard of care in terms of if you look at our guidelines. And you can also use non-platinum-based two-drug combinations. If your patients have a squamous cell carcinoma with a high PD-L1 expression, you can also go with single-agent pembrolizumab. Your other options being that you can use pembrolizumab with a platinum or a taxane. If your scoring is negative, Again, in the setting of a squamous cell carcinoma, ASCO recommends that you can still use pembrolizumab with your chemo, with your other options just being a chemo doublet alone, or even single agent pembrolizumab. If we think about these patients with metastatic disease but with driver mutations, again, we must test for EGFR, and then we look at certain subtypes in terms of exons, and just a wording that immunotherapy should not be used in patients with EGFR driver mutations, regardless of your PD-L1 status. And just to say that patients with certain exon 20 mutations can be associated with resistance to first, second line, and even third line newer agents, and especially with the mutation T790M, which I'll get to just now. So if we look at EGFR, we can have your L858R mutation or your exon 19 deletions. Those patients, we would prefer osimertinib in the first line. Osimertinib is a tyrosine kinase inhibitor, which blocks EGFR. In these patients, other options include gefitinib, which is also another tyrosine kinase inhibitor, which you can use with chemotherapy. You can also use dacomitinib, which is another tyrosine kinase inhibitor. Other options include erlotinib combined with bevacizumab. Erlotinib, again, is another tyrosine kinase inhibitor blocking EGFR, or you could go with monotherapy of these agents. And then just to say, the patients with stage 4 non-small cell lung cancer who have a poor background performance status, you can consider EGFR tyrosine kinase inhibitors as monotherapy alone. Right. This is just a wording on side effects. This is just a rash that's caused by osimertinib and other EGFR inhibitors in the group. And then there's other driver mutations. This is the anaplastic large cell anaplastic lymphoma kinase gene. They have developed new tyrosine kinase inhibitors that are targeting it, with alectinib and brigatinib being first-line drugs that can be used in the setting. If you do not have access to those drugs, and we don't in South Africa, you can look at ceritinib or crizotinib. We do have crizotinib in South Africa. In the second-line setting, if you had gone with an agent, you would use, if you had gone, for example, with brigatinib, you would use lorlatinib. If you had gone with crizotinib, then you can use alectinib or brigatinib. And then in the third-line setting, if you had gone with crizotinib primarily, and then with alectinib as a second line, then you would use lorlatinib. Alternatively, if you're in the third-line setting, you can actually use standard chemotherapy or radiation for patients as you would without driver mutations. There's also ROS1 as a driver mutation. It too is targetable by the same drug, crizotinib, which we do have registered in South Africa, but you can also use entrectinib, which is not registered here. The alternatives include standard therapy that you would use in patients without driver mutations, and then you can also consider monotherapy with other tyrosine kinase inhibitors. In the second line, if you had used a targeted agent before, then you can go with standard therapy if your patient progresses. If you had not used your targeted therapy because it wasn't available or for other reasons, then you can actually use them in the second line. And just a word on crizotinib as a drug. It's a tyrosine kinase inhibitor that targets both ROS1 and ALK. And some of the side effects include visual disturbances and gastrointestinal side effects, as well as hematological side effects. Of importance is a symptomatic bradycardia in these patients, which can even lead to syncope. And then I want to just race through these slides. So I'll just give you the mutation and the drug. So BRAF mutations, the most important type of mutations in these patients is your V600E. It's the only one in this class that's been targeted, that's been shown and recommended by ASCO. And targeting drugs, they include dabrafenib. Dabrafenib targets BRAF, but you combine it with trametinib, which targets MEK. And again, in the second line in these patients, you may consider vemurafenib. There hasn't been a lot of randomized controlled trials looking at vemurafenib, so most of the guidelines leave it up to the discretion of the physician. The other driver mutation is your MET exon skipping mutations. And again, your targeted therapy there includes tyrosine kinase inhibitors, capmatinib or tepotinib, which we do not have in South Africa. So again, alternatives will include standard therapy. Your other targetable mutations include the RET mutation that we mentioned earlier. Your first line treatment in these patients will be with selpercatinib. You can also use pralsetinib as tyrosine kinase inhibitors that are targeting RET. In the absence of these drugs, again, we don't have them in South Africa, we use standard therapy for non-small cell. Your other mutation is your NTRK, which stands for neurotrophin tyrosine kinase inhibitor, neurotrophin tyrosine receptor kinase. Targetable drugs here include entrectinib, as well as larotrectinib, which are tyrosine kinase inhibitors targeting the mutation. Again, so just in this case, we can get entrectinib under Section 21, but not available to us. And then this is new, it's from April, KRAS mutations. And again, just to say that a newer agent has been found, and it's called sotorasib, which has been shown to lead to a median survival, a median progression-free survival of about six months in these patients. Just a note to say, don't forget supportive care in these patients. If they've got anemia, investigate it, do hematinics, and transfuse where indicated. If they've got an effusion, consider thoracentesis or pleurodesis, or even an indwelling pleural catheter. If they've got hypercalcemia, do the saline diuresis and give bisphosphonates. Don't forget things like influenza and COVID vaccine in these patients. And very importantly is to involve your palliative care unit early on. Right, I am apologetic about time, but these are just some of the take-home messages in terms of what we've discussed today. And I'll open the floor to questions.